Let's dive right into this rapid-fire explainer on surgery, trauma, and metabolism. We are hitting high-yield exam pearls today, so let's jump straight into the very first clinical scenario.
With adaptation of Enhanced Recovery After Surgery, or ERAS protocol for perioperative care, there has been reduction in length of hospital stay by A. 10 to 20%, B. 20 to 30%, C. 30 to 50%, D. 50 to 70%, or E. 80 to 90%.
If you picked C, 30 to 50%, you nailed it. ERAS is a multimodal perioperative care pathway specifically designed to minimize surgical stress, optimize nutrition, improve pain control, encourage early mobilization, and promote a much faster recovery.
Let's lock in the exam pearls here. ERS reduces hospital stay by 30 to 50%. It aims directly at reducing the metabolic stress response to surgery. Early enteral feeding and early mobilization are absolutely key components. Also, preoperative carbohydrate loading is preferred over prolonged fasting. And remember, ERS protocols are applied in both elective and emergency surgeries.
Which of the following best describes the ebb phase? A. Hyperthermia. B. Lactic acidosis. C. Increased cardiac output. D. Increased basal metabolic rate. Or E. Hypervolemia.
The correct answer is B. Lactic acidosis. The ebb phase starts immediately after an injury and lasts about 24 to 48 hours. Its main purpose is the conservation of energy and circulating volume. Memorize these pearls. The phase lasts 24 to 48 hours after injury. It's characterized by hypovolemia, hypothermia, and lactic acidosis. The basal metabolic rate is decreased, cardiac output is decreased, and the main hormones driving this whole thing are catecholamines, cortisol, and aldosterone.
Which of the following is a secondary trigger of inflammatory pathways after trauma? A. Acidosis. B. Crush syndrome. C. Sepsis. D. Repeated transfusions. Or E. All of the above.
It's E. All of the above. Secondary triggers amplify and prolong the inflammatory response after trauma and surgery. Let's break down the pearls. Sepsis is a major secondary inflammatory trigger. Massive transfusions heavily amplify inflammation. Acidosis prolongs the catabolic response. Crush syndrome actively fires up inflammatory pathways. And ischemia-reperfusion injury is another critical trigger you absolutely need to remember.
Metabolic response to injury increases in proportion to A. Rising serum lactate levels, B. Advancing age, C. Severity of trauma or injury, D. Rising alkaline phosphatase levels, or E. None of the above.
It's C. Severity of trauma or injury. The metabolic response is entirely proportional to how severe the injury is. Greater tissue damage naturally causes a stronger neuroendocrine and inflammatory response, which pushes up catabolism and energy expenditure. Here are your rapid pearls. The metabolic response is a graded response. Greater injury literally produces greater catabolism. Severe trauma causes a vastly stronger hormonal response, and sepsis produces one of the most intense metabolic responses out there.
Most nitrogen loss during trauma is produced due to breakdown of A. Adipose tissue, B. Skeletal muscles, C. Smooth muscles, D. Cardiac muscles, or E. None of the above.
The correct choice is B. Skeletal muscles. Skeletal muscle is your principal source of protein breakdown during trauma. The amino acids released are used for gluconeogenesis, acute phase protein synthesis, and wound healing. Lock these facts in. Skeletal muscle is the major site of protein loss. Severe sepsis might cause a staggering loss of up to 500 grams of muscle per day. Respiratory muscle breakdown actually predisposes patients to chest infections. Thankfully, cardiac muscle is relatively spared during catabolism. And remember, nutritional support alone cannot completely prevent muscle loss while that stress response persists. Characteristic changes following major operation or moderate to severe injury include all except A. Hypermetabolism, B. Fever, C. Increased oxygen consumption, D. Hyperphagia and weight gain, or E. Negative nitrogen balance.
The exception is D. Hyperphagia and weight gain. After resuscitation, patients enter the flow or catabolic phase. Time for the pearls. The flow phase follows the ebb phase, usually lasting 3 to 10 days. It's heavily characterized by hypermetabolism and fever. Increased oxygen consumption is totally standard. You'll see negative nitrogen balance and weight loss, definitely not weight gain. And finally, increased cardiac output is a major hallmark feature here. Which of the following represents metabolic response to trauma or injury? A. Retention of sodium. B. Retention of potassium. C. Hyperthermia. D. Hypochloremia. Or E. Hyponatremia. The answer is A. Retention of sodium. Trauma activates the renin-angiotensin-aldosterone system. Let's hit the clinical pearls. Aldosterone causes sodium retention. Because water always follows sodium, this leads directly to water retention. Potassium is actually excreted in exchange for that sodium. ADH jumps in to further enhance water retention. And clinically, this whole cascade is exactly why trauma so commonly produces peripheral and visceral edema.
Which statement is true regarding extracellular fluid? A. Total ECF represents 40% of body weight. B. Plasma volume constitutes 1/4 of total ECF volume. C. Potassium is principal ECF cation. D. Chloride is principal intracellular anion. Or E. 1/3 of total body water is intracellular.
The correct statement is B. Plasma volume constitutes 1/4 of total ECF volume. Total body water is roughly 60% of total body weight. 2/3 of that is intracellular fluid, and 1/3 is extracellular fluid.
Let's memorize these fluid and ion distribution facts right now. Total body water equals 60% of body weight. ICF holds 2/3 of total body water. ECF holds 1/3 of total body water. Plasma volume is exactly 1/4 of the ECF. For the ions, the major ECF cation is sodium. The major ECF anion is chloride. Inside the cell, the major ICF cation is potassium, and the major ICF anion is phosphate.
Sepsis increases resting metabolic rate by A. 20%, B. 30%, C. 35%, D. 40%, or E. 50%.
It is a massive 50%. Option E. Sepsis induces a profoundly hypermetabolic state through immense cytokine release and extreme activation of the inflammatory response.
Energy expenditure spikes huge, often 50% above basal levels. Concluding pearls here. Sepsis increases metabolic rate by 50%. It's a major cause of hypermetabolism. Severe negative nitrogen balance is totally standard in sepsis. Skeletal muscle wasting becomes very prominent in prolonged sepsis. And sepsis markedly increases oxygen consumption. So, considering all this, how will anticipating that massive 50% metabolic spike change the way you manage nutritional support for your very next critically ill patient? Think about it.